folks.
Good afternoon, everyone, and welcome to a conversation co-presented by the Council of State Governments Justice Center and Council on Communities of Color. Apologies for the late. We are so thrilled to have you all here today. We're thrilled to welcome Dr. Fulilove and hear from Maryland Delegate Pena Melnick on COVID-19 structural racism in the justice system. My name is Shannon Moriarty with the Council of State Governments Justice Center. I'm delighted to welcome you here to our digital space today. We're so happy to welcome folks from across the U.S. tuning in for this timely and critical conversation. Today's event is co-presented by two entities within the Council of State Government, the CSG Justice Center and the CSG East Communities of Color. The Council of State Governments Justice Center is a national nonprofit, nonpartisan organization representing state officials in all three branches of government. We work in all 50 states using policy and research expertise to increase public safety and strengthen communities. Our co-presenter, the Council on Communities of Color, is the only self-identified member committee at the Council of State Governments. It is made up of BIPOC members who represent all three branches of government and provides a forum for state decision makers to examine the unique challenges facing communities of color. You can find links to both organizations on our website, in our website chat below. Before we introduce today's guest, Dr. Fulilove, I'm delighted to introduce my colleagues at the Council of State Governments who will be leading today's conversation. The first person to meet is Dr. Aisha Delaney-Brumsey, who will facilitate the conversation. Dr. Delaney-Brumsey directs the Behavioral Health Division at the CSG Justice Center, which focuses on how the criminal justice system intersects with mental health issues. Her team works with hundreds of communities across the U.S. to help people with behavioral health needs reduce contact with the justice system and advance community well-being. Dr. Delaney-Brumsey is a clinical psychologist who, prior to joining the CSG Justice Center, was the director of behavioral health research and programming for the New York City Mayor's Office of Criminal Justice. I'm also happy to introduce Debbie Antoine, who is a senior policy analyst at CSG. There, she oversees several membership committees, including the Council on Communities of Color. Debbie is a historian by training with expertise in anti-slavery politics, abolitions, and the Underground Railroad. She recently developed an app called the Staten Island African History, which I encourage you to check out. So a few housekeeping items before we get to the conversation. We encourage you to join our discussion today on social media using the hashtag JusticeBriefingLive or in the Vimeo comments box below our broadcast. We've held some time at the end for your questions, and we encourage you to use our hashtag or comments to post your questions. We will do our best to get to them. And with that, I'd like to hand it over to Dr. Delaney-Brumsey.
Thanks so much, Shannon. Having a little bit of I'm still having significant trouble hearing. I think the other folks on the panel are as well. So I'm going to start a little bit and see if that clears up. If not, when I finish speaking, I think we'll revisit if we're continuing to have technical difficulties and if that's if we'll be able to proceed or if we'll have to postpone. First of all, I just want to say good afternoon and welcome. Again, this is the first conversation in our live event series, Confronting Compounding Crises, a discussion series on COVID-19, structural racism in the justice system. And before we dive in, I want to start off by acknowledging that this has been another difficult week on the heels of a difficult year. And our hearts and thoughts are with the families and victims of the Colorado shooting yesterday, the victims and families of the Atlanta shootings last week, and with the Asian and Pacific Islander community that's been experiencing such a significant increase in hate crimes. So especially with everything that's going on, I want to thank you all for being with us here today, and I'm honored to be with you all. And I look forward to hearing from both Maryland State Delegate Jocelyn Pena Melnick and Dr. Robert Fulilove. So as I just noted, this has really been a traumatic year for all of us. We've had to face the devastating health, economic, and social consequences of COVID-19. And for many communities, that devastation not only reflects the current crisis, but also longstanding inequities rooted in structural racism. Indeed, well before COVID-19, communities of color faced discrimination and lack of access to resources, which led to poor health. For example, in major cities across the nation, communities of color experienced disproportionate rent burden, histories of redlining. Now, since the beginning of the pandemic, those same communities are facing disproportionate rates of eviction and possible homelessness. And where I'm sitting right now, here in New York City, eviction filings are happening 3.5 times more frequently in communities of color than in other communities, all in the midst of a pandemic where if you can stay home, that can be life-saving. But while the US is newly facing the consequences of having the highest number of COVID cases in the world, we've long been facing the consequence of having the highest per capita incarceration rate in the world. Even with the steps that jurisdictions took over the last year to reduce incarceration in the wake of COVID-19, approximately 2 million people are currently incarcerated in prisons and jails. And research has suggested that nearly 1/3 of Black men may face imprisonment in their lifetime. 40 of the 50 largest clusters of COVID outbreaks in the country have occurred in correctional facilities, and the number of cases is 5.5 times higher among people who are incarcerated than people who are not incarcerated. This confluence of the disproportionate impact of COVID-19 and high incarceration rates of people of color means that communities of color are facing a stark reality. In this country, we've lost over 500,000 people to COVID, and those losses have been disproportionately borne by Black and brown families. But many policymakers are taking steps to address those inequities head on and build new systems that center wellness and justice. To support those efforts, we're hosting this conversation to explore how incarceration and structural racism are drivers of health disparities, particularly in the context of this current pandemic, with the hope that understanding the history and root causes of those relationships may help spark solutions that will benefit everyone. And so I'm going to pause for a second before I introduce Dr. Full-Love. I want to get a thumbs up from Dr. Full-Love, from Debbie about, it sounds like everyone's sound is okay.
Not really. It's garbled. How am I coming across?
I'm hearing it a little bit fuzzy. And so I'm gonna just ask our tech folks to let me know if we are coming in, if on the other end we're coming in fuzzy as well, what you guys are hearing. So I'm gonna go ahead and introduce Dr. Full-Love and then take a second to check in with our tech people. So first of all, I'm privileged to be in conversation with one of the leading minds on these issues today, Dr. Robert Full-Love. His academic and advocacy work over the last 5 decades offers us deep wisdom to draw on during this crisis. Dr. Full-Love is the Associate Dean for Community and Mental Health and Minority Affairs and a Professor of Clinical Sociomedical Sciences at Columbia University. He has served on the Board of Health Promotion and Disease Prevention at the Institutes of Medicine at the National Academy of Sciences. And since 2010, he's been teaching public health courses at 6 New York State prisons as part of the Bard College Prison Initiative, where he's also the senior advisor to their public health program. So Dr. Full-Love, thank you for joining us today. It sounds like, from what I'm hearing from our tech folks, that we're coming through loud and clear to other people. So I'm gonna hopefully pose some questions to you that you'll be able to hear, and hopefully we'll be able to be in conversation today. And thank you for bearing with some of the technical challenges in this new virtual world. But thank you so much for being here.
Glad to be here. And as someone who teaches on Zoom many hours every day, trust me, this is nothing new. I'm just sorry that it had to happen at the moment when we're talking about some really important issues here. But thank you for having me.
Absolutely. So I hope I can ask you to set the stage for us a little bit, but much of the work that you've done over the last few decades in partnership with other scholars, including Dr. Mindy Full-Love and Dr. Mary Bassett, is to help describe how racism, specifically structural racism, is a root cause of health inequities. Can you both define for us structural racism as well as explain how it drives health inequities?
Glad to do that. More than anything else, we're describing a world in which one's race or ethnicity has a great deal to do with the life chances that you're likely to enjoy. If access to things like education, housing, a job, equitable employment, all depends less on merit, less on your skill, and more on what group you belong to. whether it depends for you are a member of a particular ethnic group, speaking a particular language. All of those are structures that govern how goods and services in our society are going to be distributed. If that structure privileges your membership in a race or ethnic group so that you are at greater odds of success or at diminished odds for success, depending on which group you belong to, that's what we mean by structural racism. Because it's not just attitudes towards another individual, it's how much of the way your social and economic systems are set up so that race becomes a really important factor in determining outcomes.
Thank you so much. I think that's helpful context and framing to get us started and to provide some definitions for people who may be new in the space. So I think importantly, in 2005, you offered a cautionary high rates of incarceration among people of color in the United States contribute significantly to racial disparities in health, particularly given the high rates of mental illness and infectious disease in the nation's jails and prisons. This is a reality that many jurisdictions are facing with the spread of COVID-19 in jails and prisons. What has the disproportionate rates of COVID cases in correctional facilities taught us about the relationship between racism, incarceration, and health?
Well, number one, in a state like New York, one discovers that the folk who are most likely to be in prison are folk who come from 7 neighborhoods in New York City. So there's a strong relationship between segregated residential systems and the likelihood that one will be in a community that is heavily policed, and as a result of being heavily policed, will increase the odds of being arrested, doing time in a jail, being tried for some reason or other, and then ultimately being sent to prison. If those are life events that occur largely because of where you live, in addition to what you do, then the fact that our prison systems in the United States are 67% occupied by people who are Black or who are Latinx, you begin to understand why there's such a tight relationship between the communities that you live in and the likelihood that you'll be incarcerated. Given the fact that these communities are also the ones that have high background rates of COVID-19, it becomes evident that the circulation between prisons on the one hand and between communities on the other have a great deal to do with why in both settings, rates of infection with COVID-19 are so high. It's estimated that a substantial portion of the infectious diseases that exist in communities have always been associated with the size of the jail population. And again, this circulation, because it's so difficult to do social distancing in carceral settings, has a great deal to do with why there's a heavy concentration on the inside and why that concentration has a big impact on what happens in the communities to which people return. And I'm not sure, since I'm only seeing my own image, whether I'm still connected to you all. Somebody let me know whether or not we're still here.
You're definitely still here, Dr. Volov. Thank you so much. So in the wake of recent disproportionate COVID deaths among community of color, many organizations and government institutions are paying closer attention to racism in public health, criminal justice, and related fields. And however, we know that the history of racism in this country dates back hundreds of years. Could you talk more about how COVID has exacerbated these issues, and also what do policymakers need to understand about the relationship between policing, incarceration, population health, and racism in order to make policies that improve health outcomes for communities of color?
Well, again, I want to be clear about how much racism in the United States is probably best understood in terms of residential segregation. So the places that have the highest police presence are also the places that have the highest rates of things like obesity, hypertension, diabetes. Those are the comorbid conditions that are so deadly with COVID-19. So if you think about segregation as being, amongst others, a way of identifying where we're likely to find heavy concentrations of exactly the set of conditions that COVID-19 will use to create severe illness. Then we'll understand why, at some levels, everything having to do with race dictating the likelihood of where you live, race dictating the likelihood that the community you're in will have real struggles when it comes to access to healthcare and other social services. Everything about race will determine whether or not there's a high police presence in your neighborhood. And everything about your neighborhood will have a great deal to do with whether or not the circulation that occurs between jails and prisons and the communities won't be a factor in how COVID-19 gets from one setting to another. These are all bound together. And when people talk about how much race dictates where you live, your likelihood of contact with the police, your likelihood of being tried for a crime, your likelihood of being sent to prison, all of these things have us question whether or not there aren't more effective ways of dealing with issues of social control than having so much of what we do in the United States be a reflection of what's been true in this country since the end of slavery in 1865. So everything about the way in which the 13th Amendment, for example, outlawed slavery on the one hand, but made it possible for anybody convicted of a crime to go through a period of what looks like servitude. It's another reason why we're being haunted in the present by a set of policies, procedures, and in some instances, laws that go all the way back to the Civil War and that have still produced a set of outcomes in society that have been heavily dictated by, once again, the membership, your membership in a racial or ethnic group. This is how all this is bound together. And this is why so many people in public health are saying if we're going to deal with the problems of health disparities, we have to deal with this strong relationship between race, where you live, and the likelihood that you'll have access to the kinds of goods and services that will promote health and prevent disease. Let me stop there.
Thank you. No, you're getting you're starting to get into some of the part of the conversation that I think is important to have next about what are some of the strategies that policymakers and jurisdictions are taking or could take to really address this intersection of race, incarceration, and health outcomes. We're dealing with the ongoing realities of COVID. And in order to transition us to that part of the conversation, I actually want to pull in quickly Debbie Ann Page to introduce the remarks from Maryland Delegate Jocelyn Pena-Melnick. So Debbie, can I turn to you briefly?
To introduce Delegate Jocelyn Health at the Maryland House of Delegates. She also serves as a vice chair of the CSG East Council on Communities of Color. And she's going to deliver a few words about the work that she's working on or doing in terms of health and health equity in the state legislature. Do I need to do it again? I'll start over. So it's my pleasure to introduce Delegate Jocelyn Pena-Melnick, Vice Chair of Health at the Maryland House of Delegates and the Vice Chair of the CSG East Council on Communities of Color. And she's going to deliver a few words about the work that she's doing in health and health equity in the state legislature. Are you all able to hear me?
Good afternoon. My name is Jocelyn Pena-Melnick, and I'm a Maryland State Delegate. I am the Vice Chair of the Health Committee. I believe strongly that everyone deserves good health. It's a fundamental right, and it shouldn't be, politicized. However, our society is constructed in a way that certain people are affected, and those are the Black and Brown community. What drives my interest in improving health is basically my background. I came here as a young girl, an immigrant with my mom. My mom was a single mom with my sister and I saw her struggle, learn the language, have different jobs. I learned early on that if you don't know the language, if you don't know how to communicate or find the information, it can really harm you, right? Because you need to be an advocate. Maryland has 23 counties in Baltimore City. The county with the highest number of COVID-19 cases is Prince George's County. Who lives in Prince George's County? Blacks and brown. And then the zip code with the highest number of COVID-19 cases is 20783, which is the immigrant Latino community. But why is that? It's not because of not having access to care. That's not it, all of it. It's basically that, you know, you have all these social determinants of health that affect the Black and brown community. It is the way we live, 9, 10 people in an apartment and we can social distance. Someone is positive, everyone is positive. It is the lack of transportation. It is that a lot of us are essential workers. We work with the public, we cannot stay at home. Many went to work sick. You know, it is the lack of education, the environment. Some of the bills that I have introduced this session to address the social determinants of health are all health related, right? So I have a House Bill 78, which it's called the Shirley Nate Pulliam Health Equity Act. The purpose of this commission is to bring all the departments that make up Maryland government together, to look at things with a health equity, to communicate, and to look at the different policies that they're proposing and how does that affect us people of color. The other bill I put in is House Bill 28, which requires that all health professionals in Maryland, they must take a class on implicit bias. And it also mandates a budget for the Office of Minority Health and Health Disparity, which is really important as well. Another bill I put in is House Bill 309, which sets out the guidelines for the state to collect race and ethnicity data. And that is really important. And in addition to that, the bill requires that we have a disparities policy report card every year. The policy must be guided by the data as well. And one other bill that I put in, House Bill 123, expands the use of telehealth in the state of Maryland, which is really important. So those 4 bills actually passed the House last week. So I'm very excited about that. I introduced those bills together because we must know where we come from, right? We must know that it's not just having access to healthcare, that it's also the racism that exists and the implicit bias that exists when treating Black and brown people. I think that the most important actions that lawmakers can take to address health inequities is to look at your state. How are you collecting the data? Are you providing or requiring implicit bias training for your healthcare providers? Are your departments communicating? Do you know the disparities in your state? You don't have to reinvent the wheel. You can learn from many other states. These are extraordinary times, difficult times. COVID-19 has been very tough, but we can learn from it. I want to take a moment to thank CSG Justice Center and the CSG East Council and Communities of Color, and most importantly, my sister from another mister, Debbie Page. Thank you for having me.
Nick, for offering those remarks, as well as for Debbie and Paige for helping to coordinate that. So Dr. Fulov, you just heard from the delegate about some of the work she is leading in the state of Maryland to address health inequities. And many other states and local jurisdictions are taking steps to address health inequities in similar ways, as well as drafting legislation and making public declarations naming racism as a public health issue. So in your experience, what are some of the emerging solutions or interventions that policymakers should invest in to address racism, particularly at the intersection of the criminal justice system?
I have a background in education, so I heavily favor solutions that promote education. I teach public health courses in prison, and like many people who work in the area of health disparities, I'm acutely aware of the notion that were we to raise the level of educational achievement on the part of the general society, general public here in the United States, it would result in a substantial increase in the life expectancy of the people who are that fortunate. So I'm very clear that the more we do to educate, the more we provide people with the fundamentals, the skills, and the abilities that will allow them to succeed in a variety of different settings. Understand too that the school to prison pipeline is another way in which we identify how much education becomes a key factor in any effort to promote an anti-racist agenda. The fact that so many Black and brown kids are likely to be suspended from schools, the likelihood that suspension will lead to ongoing problems with the police and with the courts and the juvenile justice system means that a lot of what we worry about when we look at the population that's doing time in prison begins with struggles that folks have in their local school systems. Segregated school systems produce segregated outcomes when it comes to levels of success, levels of achievement, levels of college going, and everything else that we know ties the quality of education so strongly to a variety of different outcomes, including health outcomes here in the United States. So improving educational equity is one of the ways in which you, in the end, will engage in a solution that in the long term, as well as in the short term, can impact the quality of health that individuals and the communities in which they live are likely to have. So it's a sort of a simplistic approach, but for the kind of conversation we're having, thinking about all the ways in which the better educated we are, the better off we are, does give you an understanding, a sort of a beginning of how I think many folk want to practically deal with the superb number of problems that are associated with structural racism. Can't hear you. You're muted. Can you hear me?
I can hear you. Are you?
Yeah.
You're not hearing me now?
I am hearing you now. No, it's okay.
You're hearing me now? Okay, great. I was saying that I wanted to ask a little bit of a follow-up on that because I know that you've worked a great deal with the Barred Prison Initiative, and that work has been to support education behind the walls and to build a public health workforce among people, at least some of the work that you're doing among people who are formerly incarcerated. So I'm wondering if you could talk a little bit about how you see that intervention specifically influencing public health and the public health's approach to addressing the health needs of people who are incarcerated or formerly incarcerated and their communities.
A lot of the factors that contribute to poor health in communities are tied up with the same factors that are responsible for having so many community residents wind up doing time in jails and in prisons. In the 11 years that I've been doing this with the Barred Prison Initiative, I've been hugely impressed by how much my students on the inside can really recognize how much life in their communities was structured in a way that almost inevitably resulted in their having frequent contact with the law and the kinds of problems that ultimately put you behind bars. Thinking that they have ways of going back, especially to interact with youth, is one of the ways in which people who see this problem and understand the community dynamics and the way in which they contribute to this problem often means that you've now got someone who understands how to be in a community, how to be a credible messenger for a variety of different ways of conducting community business, up to and including, for example, resolving debates and beefs without having violence become one of the things that people engage in. It seems to me that understanding some of the social and personal dynamics that drive health in a community, when it's someone who has the capacity to come back, to lead, to be a voice of reason, a voice that has a particular way of helping people gain access to the things they need, that's one of the ways in which empowering someone who's, forgive me, seen the light while they're doing time gives them the capacity to come home and to make a real significant difference. The large number of people who left the Barred Prison Initiative and are now doing public health work in the communities where they returned gives me a lot of hope that this is a kind of a method, if you will, a strategy that can have all kinds of benefits, not just for the system here in the state of New York, but now that Pell Grants have been made possible for prison education, I'm thinking that many states will also benefit from using something like the Barred Prison model to figure out how to do things that will improve not only what happens on the inside, not only something that will have a dramatic impact on recidivism rates, but can also have a dramatic impact on community health. So let me stop there.
No, thank you so much. That's great. And you've touched a little bit on what I want to ask you about next, but perhaps it's a little bit broader. So as you know, many of our partners are uniquely positioned to address over-incarceration and the subsequent health impacts. What guidance would you offer them as they strive to develop new policies, practices, and interventions? And specifically, what role do you think that communities of color, what role do you see for communities of color in the design, implementation, and evaluation of efforts to address the harms of over-incarceration?
Well, let me just say in the immediate future, what has been really impressive in the beginning of our struggles with COVID-19 was how many jail and prison systems discovered that they could essentially send back home large numbers of individuals who were no threat to the general public. The idea that is advanced in an editorial that was published March 3rd in the New England Journal of Medicine that basically says vaccination and decarceration is the way to go. It's a way of sort of looking at all of the steps that lead to somebody being arrested and incarcerated and asking the question, is the general public good served by bringing this person to a congregate setting where COVID-19 might be raging? Would it be better to have another decision so that instead of locking someone up, we start to look at other alternatives to deal with whatever complaints brought them to the attention of the police? Decarceration that basically says, can we carefully look not just at who's doing time, but can we find some ways in which we lessen the likelihood that we use jails and prisons as the solutions to so many of the problems that exist in communities? Thinking about, is it necessary to lock someone up, has a dramatic impact on the size and the composition of the population in a jail and prison. And because many states, many jurisdictions managed to do this, to reduce the size of at least the population they had in jail, one wonders, couldn't this kind of thinking become permanent? If we start to look at the necessity to arrest, are there ways in which, in reducing the number of people that we bring into a jail, we reduce the population of folk who are doing time there? I mean, all of the ways in which we've decided that some people with the kinds of comorbid conditions that would make an infection with COVID-19 so problematic, thinking about how to send them home, wondering whether or not people who are over the age of 55 and who've been incarcerated for more than 15 years and who are clearly, because of their health and their age, no longer a threat to the general public, do we have to keep these people behind bars, especially if keeping them there might result in a death sentence because they become infected with COVID-19 and are at an age when that infection can become deadly? These are all the kinds of strategic decisions that are informed by an understanding of structural racism, the way it creates carceral populations, and in many respects also provide us with some of the steps that we can take that might produce solutions to many of the problems, especially the public health problems that are associated with packing and jamming people inside a carceral setting. These are the kinds of things, this is the kind of thinking that's being encouraged. And it's one of the reasons why I'm myself really optimistic that if we continue this process, especially with folk who are on this conference, then great progress, I think, in the future can be made.
Yeah, it's good to hear a note of sort of optimism, particularly given that I know you've been doing this work for a long time, and so you have a good perspective on where we've been and how long it may take to disentangle the challenges that we're facing now. And just kind of building off, what you just said around thinking about interventions that sort of question whether or not someone should be incarcerated and thinking about other ways to approach. One of the key interventions that we're seeing communities implement across the country are community or health-only responses to 911 calls for people experiencing behavioral health crisis. And certainly one of the goals of that is to reduce unnecessary law enforcement contact, unnecessary contact with the criminal justice system, but also to connect people to needed supports. So could you speak a little bit about some of those kind of interventions that function on the front end and how you might see this or other similar interventions and opportunities to invest in strategies that are community-driven and are really focused on connecting people with supports that they need in lieu of contact with the justice system?
I think one of the things that one discovers when you do surveys of people who are members of the police force is how much of what they do is respond to problems for which they have no training. What do you do about homelessness? What do you do about someone who is having an obvious break in their mental health and is now acting out on the street? There are so many other ways in which problems that are associated with homelessness, and especially those that are associated with mental health, can be managed without having the police present, with perhaps the only strategy being, let's lock you up. So much of what people have tried to describe with defund the police, which is now a term that has so many negative implications, one hesitates to use it. But part of what people are saying is, are we doing the best job to manage problems of homelessness, of joblessness, of mental health by having the police be the group that has to respond? The police themselves are saying, look, that really shouldn't be a part of my job, especially if I'm really not trained very well on how to talk someone down who's in the midst of a mental health crisis. Because there are cities that have done a wonderful job of deploying other groups, particularly from, for example, an Office of Mental Health, to deal with the crises that many people who are struggling with a mental health issue are likely to have. One wonders whether or not those models can be expanded and made a part of a community response to a variety of problems that now basically only have the police as the group that gets called. Just the idea that if you were to look at all of the calls that the police respond to, where a police presence is not really necessary, could we get a sense of the scope and the size of the non-police problems that we have to respond to? And then think about making responses, budgetary responses, that provide people who do have the job of confronting those issues with the resources to do them at a moment when a crisis in a community occurs. It's just saying that we're asking the cops to do too much. It creates a kind of a disordered policing that is a disservice to the police as well as to the communities that they're in. If we can find some way of having non-police issues function by professionals in another area, one has to imagine that a variety of different outcomes, including improved community health, especially improved community mental health, will likely be some of the outcomes that we'll observe.
Thank you so much. I really appreciate the time that you're taking to walk us through all of these considerations. And now what I'd like to do in the last couple of minutes before we close out is just, we've received some questions from the audience. So I'd like to turn to a couple of those questions before I turn it back to our moderator to close us out. It looks like the first question that we got is about reentry. And the question is, how should jurisdictions prepare to receive people as they come home? What does an effective reentry plan look like?
More than anything else, my experience is an effective reentry plan includes housing. In all too many instances in the city of New York, for example, you don't get housing, you get access to a shelter. Shelters are not housing. And all the issues that people worry about when they're trying to come back home and reintegrate into life, those are the kinds of settings where that kind of reintegration will not occur. And it's even more likely that they'll be in settings and situations where all of their efforts to be good with their parole will be severely challenged. So I think of more than anything else, if we provide people with housing, we will have done a great deal to ease some of the issues that create recidivism rates. Second thing, I think it's probably the case that everybody who has actually given this some thought would agree. When you come home from prison, the longer you've been here, the greater the set of mental health issues you're going to confront as you try to adjust. The world will have changed drastically. If you went in the 1990s and you suddenly are in a setting where everybody is on a cell phone, just trying to make sense of what's going on around you can be a real task. In the United States, we do a pitiful job of helping folks deal with the mental health issues that people will struggle with as they try to adjust to a new world, a new life, and a new set of demands. The idea that, okay, you're free, doesn't that automatically make you better? When you talk to folk who have come home, they'll say that the exact opposite is true, and that they are pretty much on their own to make the adjustment. Really makes it clear that were there programs that really eased and facilitated that, so much about what we know about problems of recidivism, I think, would be confronted. And so many of the things that make adjustment to things like job or a new educational setting would also be dramatically improved. There's no question but that prisons are stressful. I don't think anybody doubts that. So the idea that we want folk to be home and have some way of adjusting to a new life after all of that stress makes the kind of sense that I think would have dramatic impacts on the quality of life that people who are returning home will have, as well as the quality of life that will be present in the communities to which they return, because their ability to adjust, their ability to adapt will be that much better. So those two, housing and work to really deal with some of the mental health issues that accompany coming home, those are things that would make a dramatic impact on a variety of things, not least of which would be recidivism rates.
Thank you. We have another question that came in from an audience member. And so they're saying that as we noted, many people in this country are experiencing job losses and evictions and other needs related to social determinants of health. And they recognize that there is some relief offered by the current stimulus plan, emergency relief plan. But how else can jurisdictions effectively meet these needs? And are there lessons from history that we can learn from here?
Yeah, more than anything else, those of us in public health worry about the damage that was done to the public health infrastructure. We struggled to get some preliminary elements of prevention of COVID-19, a major part of what people did to keep themselves safe from this pandemic. Of all the things that I saw in the bill, the idea that we're trying to redo the public health infrastructure is really important, because we are very likely to have a continued struggle in the years to come with pandemics like COVID-19. We do not want to, I think at this moment in history, be unprepared for yet another round of an infectious disease pandemic that does so much to our economy and does so much to everything about our way of life. Having a strong public health infrastructure is in part preparing for the future. Too much of what we do right now is say, okay, let's leave it to the hospitals and to the doctors to help us get out of the problems of a pandemic, and let's hope that the vaccine will do the rest of the job. In the end, those are strategies that are not sustainable. So the most important thing about this bill, and the most important thing that I think people on this call are in a position to do, is make sure that next time we have a public health infrastructure that's prepared for this kind of emergency, because they will continue to come. It's going to get worse, not better in the future. And I think we've been taught a lesson. We got to be prepared. And I'm hoping that the resources that are available in that bill will help us with those preparations.
Great. Well, thank you so much, Dr. Folov. And I believe that that's all the time that we are going to have today. So what I'd like to do is just, again, thank you for your time. Thank you, Delegate Jocelyn Peña-Melnick, for her remarks.
Thank you, Aisha. Thank you, Dr. Folov. Thank you, Delegate Peña-Melnick. And of course, Debbie Ann, for today's conversation. And thank you to everybody who tuned in. Before you go, we ask everyone to please take a minute and complete our post-event survey. You can find this by clicking the button under our broadcast or clicking the link that's now showing up in the chat or on social. We really value your feedback, and your comments will help us improve our Justice Briefing Live series. If you pre-registered for today's event, we will send you an email with a recording of today's discussion. If you did not pre-register, you can still access this recording on our website. And finally, we hope you'll join the Council of State Government Justice Center's email list so you can learn about future Justice Briefing Live events, including the 2 follow-up discussions in the Confronting Compounding Crises series. You can sign up at our website, csgjusticecenter.org. And with that, thank you to everyone for joining us today. It has been a pleasure being with all of you. Have a safe and